Hello, everyone. Welcome to our webinar, Gaining a Deeper Understanding of Patients and Healthcare Providers During COVID-19. My name is Garnett Weber. I'm a co-founder of iTracks, and I'm very excited to have two special guests today. Sheila Genuis, PhD and Research Associate with the University of Alberta in the Neurology Division, and Westerly Luth, a Research Associate with the University of Alberta and the School of Public Health. To provide a quick overview of our session today, we are going to explore the use of virtual qualitative research to understand patient and healthcare provider experiences. We'll discuss some different methodology options that can help you to achieve your research goals. And then we'll have our case study presentation, ALS Talk Project by Sheila and Westerly. Then we'll finish up with considerations for methodology selection and implementation of qualitative projects online. Just a bit about iTracks. We're an independent qualitative research technology and service provider. We developed the very first version of online focus groups in 1999, and we've done thousands of groups since. We strive to create research environments to effectively engage with patients and healthcare providers. And we have many different organizations use the platform, from universities, as you see today, brands, market research agencies, marketing consulting firms, management consulting firms, and industry associations. It's often used to inform innovation processes, product and patient journey design, healthcare service design, marketing, communications, and strategic planning. We are HIPAA compliant, and our data is stored in an ISO certified data center. We are seeing a rapid evolution of healthcare services, with many services transitioning to online environments. Similarly, we are seeing an evolution in online qualitative research. Historically, there were focus group facilities that the majority of research was done in person. And you'll see here the main focus group room, as well as the back room, where we have observers that are able to talk to each other and view the research taking place in the focus group room. Many of the online methods try to, and in different ways, recreate that in-person experience. So similarly, we have the streamed video interaction that the participants have with the moderator in the main room. And especially with the pandemic, we are seeing more and more people engage with better equipment. They're getting more used to video interactions, and we're seeing HD cameras and good quality mics. We're also seeing a rapid adoption of high-speed internet, and this is a screenshot of our new virtual platform coming out. And if you have participants with the right equipment and high-speed internet, it's amazing the quality with the dual channel audio and HD video, how it seems very close to being in person. There's a virtual whiteboard to share media and different activities, and then you can see in the right-hand corner a virtual back room where you can have this parallel video conference going on, which is very similar to the backroom experience. And for many projects, that backroom experience in real time is the place where you can have collaboration take place and be able to discuss and provide real-time feedback to the moderator to maybe help to identify areas that need further exploration in the research. When it comes to qualitative research online, there's really two main streams. It can be either real-time or overtime. And so here's the real-time method, where everybody is coming together at a pre-scheduled time. The communication could be through audio alone, it could be through audio and video, or very popular is also text chat, especially in medical studies where there's sensitive topics. Typically, there's a parallel backroom where the backroom observers can interact with one another either through video or text chat, and they can view but are not able to communicate with the research participants. They can, however, communicate with the moderator. The other stream is overtime. So this is either an online discussion board or sometimes referred to as a community. It can be of varying lengths and can have typically more participants than a face-to-face group or a video group, but we're seeing really large numbers where they can be in the hundreds. This is the methodology that we'll be showing in more detail later with the ALS Talks project. And the nice thing about the board is that is very conducive to having that real time in the moment experience. And so this just shows an example where participants can use a mobile app and record a video of their real life experience in their own environment. And that can be posted and then viewed by the others and commented on. And so this just shows an example of a patient that has, he's experiencing some trouble with the packaging of his medication, and then later learns that when he peels it back, he's actually broken the pill, which is causing some medication misdosing. So some of the benefits of online methods are that it's safe and convenient. It can be representative of the patient's natural environment. And depending on the method that you use, so for example, the text chat or board where you can have more anonymous handles, the anonymity may allow for more honest feedback or more candid about their real life situation. There's some advanced reporting outputs that can really help on the analysis and reporting side. And the mobile capabilities can capture in the moment experiences and in some ways move away from recall data, which is less accurate than if it can be captured when someone's actually experiencing it. An example of that in the moment, we did a study with 3M where they were looking at non-emergent wound care, and it was really interesting in that they could, the participants, it was over many months, and if a minor wound did occur, they could show the actual products that they used, where they stored them, which products that they selected. And so they really were able to capture that in the moment, where if you ask them at a later date, it might be hard to remember the specific details. The collaborative nature of the backroom with many people working from different environments and getting more used to connecting online, we're seeing the backroom bring in a lot of stakeholders, sometimes new to the research environment. And so being able to observe patients or healthcare providers in real time can really create a nice collaborative experience. And there are some scheduling and project management automation features to be able to create some efficiencies. All right, so next up, we will have Westerly Luth and Sheila Genuis with the University of Alberta, and they'll be talking about the ALS Talk project.
Okay.
Hello, I'm Westerly Luth. Sheila's going to hop on in a second. Hopefully. You don't want me doing this entire thing by myself.
Okay. Can you hear me?
Yes, yeah, go ahead.
Hello, can you hear me also? Or am I still muted?
Yep, you're good, Sheila.
Okay. Sorry, thanks a lot. So I'm Sheila Genuis, and this is Westerly Luth, who's already introduced herself. And we're going to tell you a little bit about our experience using a discussion board, an iBoard, an iTracks discussion board, and share a little bit about the ALS Talk project and our experience with that. For those of you who aren't familiar with ALS, that's amyotrophic lateral sclerosis. It's a degenerative motor neuron disease. It's characterized by progressive muscle atrophy and very severe disability. The disease progression is really relentless and unavoidable, and there's a life expectancy of 2 to 5 years from the time of diagnosis for most individuals. So medical care is focusing on symptom management, quality of life, and really support as people are dealing with a lot of practical and existential losses. So the communication is a really important part of medical care for people with ALS, and also for their caregivers, who are usually family members. Here's a little bit of an overview of the focus group study. We wanted to explore people's information needs throughout their disease course. And so we designed focus groups for caregivers and also focus groups for people with ALS. We had focus groups in Alberta and British Columbia and Ontario, and for people with ALS also in the Maritimes and in Quebec. In order to give you an idea of the focus group, I want to just show you a little bit of a guide for the discussions that we discussion topics that we covered. We began by talking about communication around the time of diagnosis, and we progressed over the course of the illness, so that by about the 10th week, we started talking about planning for future medical care and death and dying. There's a lot of literature about online focus groups, and the thing that was a little bit different about this group and really new to us, a new experience, was that we carried it on over a very long period of time. Each discussion topic was open for input from our participants for 2 weeks, although we rolled out questions over that 2-week period, so that there was a group of questions at the beginning of the first week for the discussion topic and a group of questions at the beginning of the second week. You'll see that we also did 2 optional topics. At the end of the focus group, we opened up a topic specifically about participating in observational research, and we're going to present some of the results from that 2-week discussion today. And also, because the discussions or the focus groups were rolled out over a period from January to, they beginning in January, and the last one finished in about July of this past year, our participants we were right in the middle of our COVID really hit right when we were in the middle of focus groups. So we also opened up a discussion space talking about the impact of COVID-19 on this very medically fragile population. And we just left that open. So there was a lot of flexibility within iTracks to pivot on our feet a little bit and to open up another discussion area. We took these discussion topics and then translated them into what you need to put online on iTracks in order to stimulate discussion, and Westerly is going to address that a little bit.
There we go. So we're just going to go through a couple examples. This is one of the questions that we developed, looking at what other information sources aside from somebody's doctor that they would seek out after a diagnosis. And we really tried to make sure that we framed the questions to be as inclusive of people's experiences as possible. So not only the people who did, but the people who didn't. What we found, the way we structured these questions, we used a lot of the iTracks capabilities in terms of polls, which were really great, not only for asking people like quantitatively what they were experiencing, but then they became a way to stimulate discussion, because after we did the polls, we could ask people, you know, you talked about living with ALS was something you looked for information for. Were there specific things you were looking for? We got some really interesting stuff about CBD we weren't expecting, which was fun. One of the other things that was really cool about iTracks is we could decide whether or not to make the question influenced or uninfluenced, so that the initial response that we got was not biased by other people's responses. And then once they had given that unbiased answer, they could see everybody else's discussion points, and so they could actually respond to each other, which made for some really interesting co-creation of knowledge between the different participants. This is another question that we put together that used some really cool iTracks technology. So this is a, I don't know, I guess a ranking question. There we go. about what inspires people to participate in research. So the most important to the least important. And this was also really cool because not only do we get that very quantitative, like 1, 2, 3, 4, 5, 6, 7, but then we got some really interesting results in terms of qualitative topics as far as how people experienced the communication around people trying to recruit them to research. So we had quotes about how people experienced being ineligible for research. So it's not only the good stuff, but we got a lot of the maybe stuff that needed a lot more improvement. So let's see. Yep. You want to take over this part, Sheila?
Okay, so those questions illustrate the really interesting ability to use quantitative and qualitative data to then stimulate really in-depth qualitative response from the participants and to play back and forth with those things a little bit. But moderating for this type of focus group, and particularly because we did it over the long term, remember we were engaging people for about 4 months, required some really significant moderating commitment. So in terms of group management, the early relationships were built outside of iTrax through the recruitment process. But then within iTrax, there was this capacity to do email broadcasts. So we did weekly email broadcasts to each focus group, and we would let them know about upcoming topics. We could address any areas of concern that might have come up that we wanted to do sort of a general communication. It was really important when we started to draw close to the more sensitive topics to let people know that it was coming, to tell people they, to respond in their own time, that they could choose not to answer certain questions. So those email broadcasts were a really important part of that group management. We also did a lot of individual correspondence and reminders with people if we hadn't seen them in the focus group for a little bit. As Wes mentioned, the uninfluenced mode was a really important part of the capacity for sort of group management, but you could also people could choose to make the responses private, and some people did for various reasons. We could also make people's responses private if maybe they were talking about something that shouldn't be shared with the whole group. And then we also accommodated participation breaks. Do you want to flip to the next one, Wes? Thanks. There was a lot of day-to-day management. We had a really significant involvement in terms of moderating. We popped into the groups 2 to 3 times a day, 7 days a week. We acknowledged all posts and did a lot of individual probing, like a lot of soft skills, reflecting people's language back to them, asking them to tell us a little bit more about a certain experience, or drawing them to some other aspect of the question that maybe they hadn't addressed in the first time around. So a lot of individual probes, and also then summaries of what people had written and inviting other people for input. So we ended up with kind of these 3 dimensions of conversation threads between the moderator and the group, and the moderator and the participant, and then between the participants as they built ideas together. We're going to focus a little bit of discussion of results on that optional question, but here's a little bit of an overview of our recruitment. And we kind of, because ALS is such a ferociously progressive disease, we lost people even during the recruitment period to disease progression, to death. But what we kind of look at as our starting point is who got to the point where we managed to get them through the technical challenges, got them onto iTrax, and they gave a personal introduction. So for our very medically fragile population, it's also a little bit of an older population. Average onset for ALS is 58. So we had some people that were in their 70s and maybe a little older even participating, as well as some people that were younger. And many people were really fantastic from a technology point of view, but there was quite a bit of we did lose some people who just couldn't quite get through the technology. So maybe next slide, Wes, and you could talk about the results from that optional discussion topic.
Sure thing. So we had some questions about studies that do not involve a treatment. Obviously, people with ALS are very keen on that whole cure idea. But we wanted to hear what their preferences for hearing about research opportunities for these more observational studies. This was all based on another study that our PI was involved with, and they had a focus on a much longer term observational study, and ALS Talk was a great platform for them to ask some questions to the people who would actually be involved in a study like that, and to make it very patient oriented from the get-go. The other things we asked them about were what research should give back to participants, what they would value as part of their participation, and what considerations they would think about for longer term studies like a year. And for ALS, that's a big chunk of time. We also asked them about data sharing, with open science being a very hot thing these days. It's good to know what participants would think about having not only their data, but their biosamples shared between not only different researchers, but also for ALS, the pharmaceutical companies can also be very involved in research. And so when we did the analysis of these questions on observational research participation, we found 3 key themes or primary themes. Research is a partnership, practicality is important, and data sharing is acceptable. And if you'll remember, about 100 people did their introductions for the participation for this optional discussion. We had about 32 people in total, and some people didn't do all the questions. People vote with their feet, and they choose what to engage with as it interests them, and that's just sort of the nature of the beast. In terms of our themes, this is another one of those very qualitative analysis. So Sheila did the lion's share of the work, but contributing to knowledge as a sort of broad idea. And then we have quotes on the other side of the arrow, just looking at not only like why people participate, which really speaks to the that desire to give back, that desire to build, that desire to have sort of a legacy beyond their disease, I guess. And what participants want back, this is a little bit more quantitative, but also a really interesting thing because we got all of these different categories of interest. People were very interested in knowing about their data. People were really keen on having interactions with health professionals. The one that surprised us was people were very keen to have their results compared to average. And when we probed on that, which was really useful, what we found was that people were thinking of this as a tool for prognosis so that they could compare themselves to other people with ALS and then use that to sort of guide their thinking about where they were in their own disease progression. The other more quantitative bit we got for the practicality is important theme was looking at how to make research less onerous, basically, on people with ALS and their caregivers in order to facilitate that longer term commitment. Oh, I think this one's yours, Sheila.
Yeah, so the third theme was related to data sharing. And as Westerly mentioned, of course, open science is a really important concept. And whereas we found that everyone that responded to the question was perfectly willing to share their data with researchers, other researchers across Canada, so beyond the team that they were directly interacting with when in a research project, the question was, would they be willing to share their personal data, potentially genetic data, and biosamples with for-profit pharmaceutical companies? We found it quite interesting that, in fact, only a very small number of the 26 people that answered this question, only a very small number said, no, I'm not comfortable with doing this at all. There was a pretty large group that basically recognized this is a horrible disease, and unless we share with everyone, we're not going to find an answer to it. So that was also a pretty decent chunk of people, but the largest group was this group in the middle that said, no, I won't share my data unless you do this. Or they said, yes, I'll share it, but I really want you to do this. And those concerns and caveats included some of the things that are listed here. Drugs are very expensive, so people wanted some idea that maybe if they shared their data, then costs for people with ALS would reflect the contribution that they were making. So this again speaks back to the incredible importance of engagement with researchers, that researchers need to look at people who are participants, not as guinea pigs, which is a direct quote from one of our participants, but as partners in research. And if there is really good communication between researchers, that they talk to participants about these issues, the concerns they have. There are many people that will go on board with, certainly the vast majority of people will be on board for sharing data with for-profit companies. And I think ALS is a bit of a unique disease because there is no cure, and the disease is so rapidly progressive that people are really looking to research as sort of an answer for ALS. Would you mind going to the next slide, Wes? Thanks. So just in a bit of summary, this was a new experience for us to work with an online asynchronous focus group, and the long-term nature of it presented some challenges, but we also found phenomenal strengths. Really amazing rich data generation, both the quantitative as a way of probing and creating topics to talk about qualitative, and also the depth of response that people gave us. We were able to create a safe space through this platform. People controlled their own level of personal revelation. They could choose what name they used in the group. Some people shared email addresses or blogs that they did, and some people were really didn't share that kind of personal data. People can engage at their own level of comfort. And one of the really important things that ties down into the accommodation is that people could reflect on the questions and respond in at their own pace. So this meant that for our participants who were using really specialized communication software, because many people with ALS will lose the ability to speak, and so people used really sophisticated communication software like eye gaze. This gave them the time to slowly create their answers. So for people that are nonverbal, this gave them an opportunity to participate in a group where, when face-to-face conversations are potentially not possible or very difficult. It was also a very amazing way of building relationships over the long term with the participants, and a unique opportunity for these people who often are very isolated by their illness and by the illness, for the caregivers, for the illness of their loved ones. They really value the opportunity to interact with other people and to share practical ideas for dealing with the disease, and also just personal support. There were also some things to think about with using the discussion board. And remember, we're talking about a really medically fragile population, a little bit of an older age. And so there were some of our concerns might not be relevant to the projects that you're thinking about. But the timing between recruitment to the beginning of the online focus group was really important. We're in a research environment. Our collaborators are in other research environments, or are there clinicians who are focused on caring for patients. So recruitment was a challenge from the time of beginning recruitment to the time that we could actually had enough numbers to start the online group. It's really important to beta test. We had a participant advisory council. We beta tested some of the kinds of questions that Wes that Wes illustrated earlier, so people could give us, so we had feedback on that before we started the group. It's a huge time commitment. Moderating was a big commitment for us, really rich experience, but it definitely was a time commitment. And also the sort of personalized technical assistance. Wes spent a lot of hours working and doing a bit of hand-holding with people as they navigated the variety of devices that they were using. I think you also have to think about the best number in terms of group members. This was a learning experience for us. We did start the group in the Quebec and Maritimes with a smaller number. It was also the nature of those participants. We had people that got too sick to participate. participate during that time period. So that's something to think about depending on your population. And as was illustrated by the slide that Wes spoke to about the number of people, we had 32 people that engaged with the final that optional discussion topic. But for example, the question about data sharing, 26 people gave response on that. So the number of people involved, changed from question to question. So thank you for listening to this little presentation about the ALS Talk project. We're up to our eyeballs in data analysis right now. We're so grateful to our study participants, to the collaborators who assisted with recruitment, and to the research fund that funded the research, which is incidentally, it's the money that was donated to our boss, the principal investigator, Dr. Wendy Johnston. This money was donated to her by a patient and the patient family. So we'll turn it back over to Garnet now.
Great. Thank you so much, Sheila and Wes, for sharing your very inspiring project and a very unique and creative use of online qualitative. Next, we're going to go through, I just want to make sure I'm showing my screen all right here. There we go. Next, we're going to go through, actually, I wanted to mention fantastic information, amazing experience, and I'm sure there's lots of questions. So please enter your questions now in the GoToWebinar question panel, and we will be having a Q&A session. We've left the last 15 minutes of the session today for a Q&A session, so we want to have time. So if you can start entering those questions now, that'll be helpful, and we can make the best use of that time. Next section here, we want to talk a little bit about the methodology selection and design considerations for online qualitative projects. The method that was used for the ALS Talk project was the online discussion board, and it has a fully featured web-based platform, and then the mobile app can do all of the communication as well, maybe not some of the project management capabilities. And with the ALS project, they made a heavy use of the text responses and the polling questions. And in addition, depending on the nature of the study, the audio or video can be important, as well as sometimes for some studies, it's helpful for participants to be able to attach images or media photos from their phone or desktop and be able to attach those to their response to be able to express themselves through their media. For iTalk's board projects, so if you're looking at the different options, projects that work well on the discussion boards are ethnographies or diary studies, because you can get that daily input or show the patient's life in their real environment. We've done several studies where it's worked well for looking at the uses of medical devices, whether it be injection devices or perhaps respiratory inhalers for medications, and various package tests for pharmaceutical or other products. We've also found that it can be very helpful for engaging healthcare providers and situations, especially if you have healthcare administrators or perhaps employers that are also interacting and you want that collaboration with the healthcare providers. We see that often administrators will work more in the sort of 8 to 5 period of time, and then healthcare providers with their schedules, often they will log on to something like the online discussion board in the evenings or weekends. And so with that asynchronous posting, you can get that reflection and then that inter-participant engagement talking about the same topics. Patients that are challenging to schedule, such as with the ALS patients that Sheila and Wes described, it can be very helpful just giving them that flexibility to participate when it works well for them. And then also when you're managing groups with different time zones, it can be really helpful. The other use that I've seen it work well is when sometimes for projects you need different phases. So whether it's a project that is evolving over time, or we've also had projects where it may be a healthcare issue that you're having different people collaborate on. And I have seen projects where, worked with projects where perhaps there's a base level of education or understanding to make sure that everyone's on the same page. So that might be a phase 1 with some preliminary information, and then going on, maybe having a gap to do some analysis, and then a phase 2 where you can look at more of that interaction. And the board works really well if you need people to move in and out of phases of research. Just a few tips for executing projects using an online discussion board. You need to develop your rapport through that discussion guide. And so Sheila and Wes did a fantastic job of this. And when we looked at their guide, they really helped to create that relationship with the patients. And depending on your patient population, if you can have those little personable pieces that you would, just as you would in a face-to-face environment, it can be really helpful to increase the comfort level with a research environment. Very important to acknowledge the participants, acknowledge their point, or acknowledge when they've spent a lot of time reflecting or composing a post. And that acknowledgement, and if the moderator takes the leadership in acknowledging posts by participants, it really helps to engage them. And then we also see it's a lot of modeling to get inter-participant engagement as well. A colleague of mine did research on research where he looked at a number of studies, and the #1 factor in triggering that inter-participant engagement was moderator posts. So they were very highly coordinated. If you had an active moderator, you would have higher activity amongst the participants. We recommend having days where there's no new questions posted, and the participants can then take that time to review what other participants have said and post on their comments. And then you get the threaded discussion evolving. For projects where you would prefer that participants use video, we encourage moderators to post videos themselves, and that increases the comfort level with video content, and it also shows the participant they don't need a professional level video interaction, so they're able to see that it is that regular everyday video that we're looking for. I recommend pacing the questions. So especially day 1, you want to help them to warm up. Often there's a bit of an icebreaker that's really about getting to know each other and not requiring too much brain power before you get into the real meaty questions. And in terms of timing, I mean, every board is different. Obviously, if it's going over the course of several months or a year, they probably wouldn't be expected to participate on a daily basis. For shorter boards, usually there is more of a daily expectation for participation. So outlining those expectations up front and targeting, likely 30 minutes is would be a useful target area. Sometimes there's incentives involved, or often there's incentives involved, and so the incentives can help if there's a higher time expectation for participants. I encourage you to make use of the different segments or subgroups to help with that, managing larger groups. And then on the reporting side, that can really help when you export the reports. You can just look at specific subgroups within that. And Wes mentioned the uninfluenced questions, so that can be helpful to avoid that groupthink challenge where the participants have to post before they'll see the responses of others, and the interview styles for the interview question mode for those sensitive topics. The other method to consider, now we'll talk about a few real-time methods. And so text-based focus groups can be very engaging and helpful, especially in healthcare environments. And I just wanted to quickly touch base on this very interesting study that we did with Sabine Vaccine Institute, and Sherry Dorfman from Stepping Stone was the main primary investigator in that study, as well as we had 3 additional local language moderators to be able to moderate in German, French, and Spanish. And this particular group, they were the patient population, or actually it was a healthcare provider population. They were in very rural and remote areas, and they were looking at vaccine access and factors. And so with the participants, well, they had internet connectivity. It was very inconsistent and low bandwidth. So this was definitely the method of choice in that it has very, very low bandwidth and system requirements, absolutely no. They basically just need to go to a web page, and if the internet is inconsistent, it will just take a little bit longer for their post to come up. So it was highly effective, and with the automated transcripts, it was really helpful in that the questions could be designed in English, it could be translated into the local language, and then the questions programmed in the local language. So it's just each question, you just click a button and it posts it to the group. And then the transcripts can be downloaded on the back end and translated. And it was a really quick turnaround to then allow Sherry to do the full consolidated report covering all of the different regions. So that example, I was wanting to show that, especially with the low bandwidth, it can be a great fit. Projects with a lot of, if you need to cover a lot of questions and you only have your participants for a short period of time, this would be the method of choice. Most people can read and type faster than they can speak. And so, and then there's also a time savings if you compare to, say, a video or in-person group. When you say a question, you have to give everybody time to think through the question, and then you each have to take turns to express the answer to the question. And so with a text chat group, you get an efficiency in that when you post the question, everybody can simultaneously think and type their answers, and then as you read through them and they read through each other's answers, there's a significant time savings in that the responses are all through text. If you are wanting to engage a larger number of participants in a real-time setting, this would be the topic of choice. Once you get into the larger groups, it's hard to cover as much content in a video group, again, because you're taking turn to express your answers. It's ideal when anonymity is important, with no video sharing, or sometimes the handles can be movie stars or unique names, so then that they can have complete anonymity for sensitive topics. We are seeing it popular for teens and millennials. Some of the the youngest generations are very expressive. They've grown up with texting, and they are very expressive through typing. And helpful for those quick turnaround projects because you've got that transcript. There's no delay in terms of doing transcription, depending on how you're doing your analysis. And we've also seen it popular for media heavy studies. So if you're showing a lot of media, the whiteboard area can be quite large. You can view that media and you don't have the distraction of the webcams taking place at the same time. So some tips for chat. It's a definite must to pre-program your questions. It moves very quickly. So if you can have all your media and questions added to the platform in advance, it's just clicking and it puts in those pre-programmed questions or media displays. And then the moderator can focus their communication on the probing and additional questions. As I mentioned, you can get through more content in a text chat. And the uninfluenced question option is also available in the text chat, where you can post a question and everybody has to respond before they would see the responses of others. We've seen some groups where the back room that's watching the chat, they can communicate with each other. And sometimes we've seen hundreds of people, typically not that large, but we've seen some projects where they're really trying to immerse providers so that they can view the participants and create empathy. And so if you have a large number of people in the back room, you may want to consider having a facilitator to also help in the back room. And if there is feedback to the moderator, especially if there's a lot of backroom chat, you may want to have a point person that then will message the moderator with specific points that they want to have brought up in the research in the discussion. And one thing that we found really helpful for those multilingual groups, such as this Sabine Vaccine Institute, there is a Chrome extension where you can have the page translated in real time, and then you can still view and understand a group that's in another language. The next method that we'll talk about is using video. So that would be for either focus groups, or it's also used for one-on-one interviews, which is really common for healthcare provider studies because it's hard to schedule them to all collaborate in a group, finding a time that will work well for all of them. And so this is our new virtual video platform that we'll be releasing in January. And again, you can have that main room interaction to the left of the gray bar, and then the back room and different discussions and controls on the right side. And with the video groups, projects that work well, if you really want to have that facial interaction with the participants, video is the route to go. And it's also a method of choice depending on your reporting needs. So the reporting of a video group is superior in that you can potentially have those high impact video clips. And depending, if someone missed the group, you probably want to have the mosaic so that they can see all the video interaction simultaneous. But then the other reporting output would be the single stream video. So if you are going to, say, present the key video clips on a larger screen, as you expand those, then you want to have a really high quality single stream recording, and have the audio where, you know, if there's a dog barking in another video feed, then you'd have that individual audio clip that can be really helpful to enhance the reporting outputs. Depending on your study, if the backroom experience is really critical to the study, then the video method is really helpful because there's a lot going on and they can really benefit from seeing the participants in a video environment. And it's really, having that video really helps to create patient empathy, especially within the backroom or stakeholder groups. So a few tips for video interviews: use time selection to automate that scheduling and improve show rates. Encourage you to maintain eye contact with your screen, which is really your camera. So we encourage you to add your questions to the platform so that you can maintain looking at the screen, not down at a paper or something else or another screen, and having everything occur there. If you're looking at your screen, it'll help to encourage your participants to maintain eye contact. It does require more active moderation, a lot more directing, sometimes drawing out quieter individuals, making sure that no one's dominating. Again, sometimes a facilitator in the back room can be helpful, and definitely a debrief session. You've got all the observers, everything's fresh in their mind. It can be a really great experience for the observers to have to talk about the session afterwards. And then accessibility considerations, some of those were mentioned in the ALS talk presentation. In terms of patients with different needs, we had a study with Parkinson's patients. Again, their voices can be impacted, so having technical support to maybe help with the volume control so that they can be heard, and the visuals, making it really easy, and a platform maybe that isn't too many steps to get get into. So having something that maybe doesn't require a download or any complicated steps to get started. All right, so we'll now move into a question session. So We can have questions on any part of the webinar. Sheila and Westerly are available as well to take questions on the ALS Talk project as well. So, and you can enter the questions into the chat area of the GoToWebinar panel, and I will moderate the questions. Okay, so first question here, can iTalk's board work well with healthcare practitioners? Based on your experience, how long should tasks per day be for this group to avoid fallouts? Yes, the iTalks board is would be personally, it would be my method of choice if you need a lot of healthcare practitioners interacting. We've done a number of studies. I recall one with, we had physical therapists, occupational therapists, employers, regulatory professionals in a regulatory role with regulatory bodies, professional associations, educators, and support personnel. And so we had all of those people engage in one project simultaneously. It was over 100 participants broken down into subgroups. And for that study, the sweet spot was we tried to make the questions around 30 minutes. Some were super invested in the topic, and so they would stretch that to maybe 45 minutes. But you can't keep up at that pace for a long period of time. And so what I found with that project, the best practice was to have questions one day and then have a day off, and then questions again and then have a day off. And so basically they had a week to do 3 days of questions that had about 30 to 45 minutes per day, and that worked well. And then we gave the weekend as sort of that catch-up period. So if they had missed the questions, the nice thing about the board is they still can go to day 1 or 2 if they weren't able to do those during the course of the study. Do you have any recommendations for the recruitment phase and verifying potential participants' identity? So recommendations. So recruitment is definitely a challenge. Maybe I will pass this on to Sheila. Sheila, do you have any recommendations in terms of recruitment, especially with your experience with the ALS Talk project?
Yeah, because it was a research project at an academic center, we had certain ethical guidelines for the way it had to be recruited at the different clinics by someone who would then pass on contact information to us or give people our contact information. So we had some restrictions based on being an academic institution. But then after we made contact with people, what was really, really critical was sort of to keep in touch with them. So once they were recruited, while we were still recruiting other people, I did send out a lot of emails sort of letting them know where we were at with recruitment, so that they began to feel a little bit invested with the project and as though they were part of it. So a lot of relationship building during that recruitment period. We were not confronted with the issue of like people's identity because the people came to us either, also the ALS societies in the different provinces put out a lot of information about the study, so people contacted us directly who had heard about from the ALS societies. But we're not in a situation where identifying people would be a concern, because these people have ALS or their loved ones get caregivers.
Mm-hmm.
Yeah. It's not a club you want to belong to.
Yes, yeah. And I think we're sometimes a challenge depending on the source of the recruitment, where the sample's coming from. And there's a lot of studies that have an incentive associated. And Wes, was there an incentive associated with your project? Yeah. So
no, there wasn't. But what we did find was the ability to make the link specific to a particular email was a really good way to make sure that we were getting whatever recruitment messages we had directly to the appropriate people.
Yeah. So I can speak to, there are some studies where verification of participants is absolutely critical. And especially if there's a higher incentive attached to the project, I think the risk of having participants who maybe aren't who they say they are is absolutely essential. And so there's a number of methods. Some of the panel the recruitment providers have different methods of pre-verifying, making sure that people are who they say they are. One thing that we have found highly effective is in the recruitment process, there's a screening process, but iChecks will often have if we're supporting with the recruitment, we'll have the participants do we call it a video articulation question. And so often we'll have a question that they would need to be somewhat knowledgeable about to have a proper answer. And if there are, it can definitely be a detriment. So if someone is maybe posing as someone that they're not, and then you're asking them to post a video, it can be a detriment, and we'll often see them drop out at that point. And so that might help, and then you can review those videos in advance to ensure quality recruitment. And then, yes, depending on the source, so obviously through a society or a membership, you're going to have a very high authenticity rate. How do you keep doctors engaged in text chat? And what is the ideal length of a discussion? So with the text chat, that's again a real-time group. And so with that, in terms of length, those are typically, we see 60 to 90 minutes are the most common, probably 90 minutes the most common by the time you do an icebreaker, go through the content and some wrap up. And that would be similar to when people conduct face-to-face focus groups. And in terms of physicians, the challenge with physicians for a real-time group is going to be that recruitment and finding a common time that they're all going to be available. So we often see with physicians it being either a discussion board or a video interview, because those give the most flexibility in terms of the participant being able to direct that time. We have seen physicians and healthcare providers come together in text chat groups. And in terms of engagement, actually, we see very high engagement levels in the text chat groups. It moves fairly quickly, and you can tell there's an indicator at the top when someone hasn't responded, and so you can really engage. Most physician studies would have an incentive attached as well, which might help with engagement. Okay, any other questions? Feel free to enter them into the GoToWebinar panel. Okay, ALS talk. Do participants know they have the liberty to choose questions they're comfortable to answer? And did you end up with questions with a very small base? How does that affect your study?
So it was very clear in the introductory material that people could answer questions as they felt comfortable to do so. But for each topic, there were quite a few different questions. So when people weren't present in the focus group, it was usually because of illness progression or something related to disease. People sometimes chose, we noticed a little bit of a drop when we started talking very explicitly about death and dying. But that was built in as that, of course, they had to have the flexibility to do that. We never had such a significant drop that we that we were concerned about data integrity, because we didn't have perhaps enough data in some areas to do a provincial breakdown, but in terms of the whole group, we certainly had enough participants to have very robust discussions or robust data.
Yeah, we only had to use the mandatory questions for consent. I think was the only consent, and the introductions were the only things that people absolutely had to answer. And part of that was that building that safe space, right, so that people were the ones in charge of what they wanted to share.
And the discussions were rolled out over time. So it wasn't as though people had all those discussion topics in front of them and it would be overwhelming, but they were put out every 2 weeks. And people could go back and answer questions that were further back, but they tended to move with the focus group.
And some people definitely, I think, again, with the death and dying questions, some people took their time sort of coming to it and collecting their thoughts and reflecting on it before interacting. But I think making sure that nobody felt pressured was really important to actually getting any responses on those.
Great. In any of the formats, is it possible for participants to direct message each other privately? So the the direct messaging is it's not between the participants on a private basis. It is there's direct private messaging from the researcher to the participants is the most common form. And also in the new real-time tool that we have for text chats and video chats, there is direct messaging between observers, so they can have sort of side conversations privately, and then also private conversations between the observer and the moderator. Great. Okay, so we are at the end of our time today. I thank everybody for coming, and a very special thanks to Sheila and Wes. We really appreciate you sharing your experience with the ALS Talk Project. Thanks, everyone. Bye.
Bye.